Everyone, and welcome to this first webinar in the research course on rehabilitation research. To introduce myself, I am Dr. Kavita Raja. I completed my initial physiotherapy education in CMC Vellore in 1984, following which I did PGDR in Bombay, my master's in Texas Women's University, USA, and subsequently PhD in cerebral palsy gait from Manipal University in 2006. I have been teaching, treating patients and doing research since at least 1992. I have been treating patients since 1984, of course. And research has always been of great interest to me, especially because rehabilitation research by itself is not very well understood in our country, and the potential is tremendous. Hence this course. Now, the course was initially conceptualized in order to, because of the gap that exists between clinical practice and academics and research, because academicians and researchers are seen across the world as a class apart from clinicians, whereas that should not be so. We work together because all of us should be practicing evidence-based medicine, evidence-based physiotherapy. Then coming to the research in physiotherapy in India per se, there is an obsession with RCTs, and for some universities actually accept only RCTs from their master's students. So this is not entirely the appropriate way to approach research, I feel. Then there appears to be a lack of innovation and imagination in research topics, and we tend to redo the same topics over and over again. So especially if you look at the master's topics lists across universities, there seems to be repeating topics, mirror therapy, this, that, whatever is the latest trend or latest craze. So that appears to be there is not much innovation or not much thought about what is relevant to India. Then there appears to be a very casual use of outcome measures and measurement. People are randomly using outcome measures that are developed in other countries without appropriate validation for our country. And measurements are being used also without a great deal of thought into their psychometric properties or into the sources of error, threats to internal validity. So these are essentially, if the measurement is inaccurate or potentially inaccurate, then that raises questions about the worth of the research itself. The unmodified use of intervention strategy is another thing that is of concern to me. That is, there is some intervention that has been widely publicized or widely reported as being effective, and we almost blindly follow it sometimes without thinking about how useful it would be in our situation, how useful it would be for our patients, and so on. So I'm not saying that we cannot take what is done elsewhere. We need to, because by and large, whatever is relevant in one country is going to be relevant in another country as far as healthcare goes. But we might need to do some modifications. So we need to think a little bit more. Then there seems to be an over-dependence on comparison and correlation studies. And you're saying we're comparing this against that, we're correlating this with that, and then when you get this number, we're happy, without thinking about the clinical relevance. Or is the comparison actually comparable? Are the two groups comparable? Is the correlation meaningful? So these kind of things are again of concern to me. Then there appears to be confusion in certain quarters about the hypothesis and the null hypothesis, and this driving need to get positive results or to reject the null hypothesis, as if negative results are somehow less important than positive results. So these are again some of the problems that we meet, that we deal with every day in the research field in physiotherapy in India. Then there is, of course, the complacent use of the magical P. If P is less than 0.05, everybody is happy, without really thinking about whether the difference itself was meaningful. So these are some of the burning issues that I feel are not adequately dealt with in research classes or in research seminars, which is the reason we thought of this course. Now, this course, I'm happy, has attracted 9 participants. I had not even expected this many actually. I hope this will be a beginning for more of these courses to happen across the country. Now, coming to what is research. Now, there are many definitions of research, and I'm not going to go into it. And a lot of it has already been given to you in your in the material that was given prior to this webinar. But the core component of research is that it is a systematic approach. This systematic approach is the key here. It's a systematic approach to either establishing known facts. We already know something, but we need to make sure that it is established empirically. We have known that, for instance, we probably know that when you give heat, there is a certain relief of pain. Now, is this consistent? So these are things that these are known facts, but they may not have been proved empirically. So research would be one way of establishing this and knowing whether it actually is consistent and constant over time would be through research. Identifying new phenomena. This is observation. Okay, if you keep your eyes open and if you're looking for new things, if you're always on the lookout for new phenomena to happen, identification of new phenomena would be research. Once they are identified, then you might want to look at the cause-effect relationship. Then we would want to find out if it is consistent and so on. Then measuring empirically. We quite casually say that if we do this treatment or this particular strategy, our patients feel better. What is better? Now, better has to be defined. If not, we do not have anything to report. And these things are essential. So that would be measuring empirically. So measurement. How are you going to measure? What are you measuring? Is the measurement appropriate? This would be research. Then, of course, you need to analyze what you have measured accurately using the correct statistical methods. And you cannot just randomly use whatever is easiest to do, which is obviously a temptation that young researchers have or students have because they have to submit a thesis. The analysis very often across the world and also in India is done by a statistician who is not a physiotherapist or who's often not even a medical person, and they are going to analyze whatever you tell them to analyze. You say, I want A compared to B, they will compare A to B. Now, that analysis is just a mathematical analysis. Whether it is meaningful to you, to the human being, to the people that you're treating, is your job. That is not the statistician's job. The statistician is going to say this is decreased by this much, or this much percentage, or this many points. Whether that is important in a clinical sense, that interpretation has to be done by you and me. So interpreting analysis meaningfully is an important part of research. And then, of course, probably one of the most important things would be reporting. You need to report, and you need to report honestly so that other people do not have to reinvent the wheel over and over again. So, and the honestly part is also very important because a lot of our research is very painstaking. You have to do exercises for 6 weeks minimum to see any sort of effect. So 6 weeks you have to do probably the same exercises with the same patient for 2 hours, and it may get boring. So there might be a tendency to not do it the way it should be done. So this should not be done because we need to report honestly. What is rehabilitation research? Why rehabilitation research? Rehabilitation research is probably the same as medical research because rehabilitation is a part of research. Of a part of medicine. But there are a few differences. Rehabilitation research is an entity by itself because rehabilitation is not, many of our outcomes are not measurable. Our questions are different. We want to know if what is going to happen to this patient. How does a disabled person manage? How does a person who's a stroke survivor manage his ADL? Now the ADL can differ from you to me to somebody else. So the questions that we are dealing with or the problems that we're dealing with are slightly different from mainstream medical research, where it's slightly more easier to control. If it is a drug trial, you're giving drug A, drug B, and you're looking at some, I mean, they are looking at some outcome that is measurable, like blood levels or some markers, biochemical markers or something, which is not really altered by the environment or altered by society or altered by attitudes and so on. Whereas our questions are different. The things that we do are altered by so many other factors. Like all of you are familiar with ICF. Everything, body structure, function, activity, participation, everything can be modified by context. And therefore, our questions are different, and therefore, a greater emphasis on measurement being accurate and measurement techniques. The methods that we employ are also different. It is not easy to do, or it is almost impossible to do a double-blinded study. How can you blind a person when you're giving them an exercise? They know that they're getting exercise. They're the ones who are doing the exercise. So these kind of controls may not be possible, which is possible in medical research. Uh, research tools are very often different. Our research tools are heavily emphasizing the subjective aspect because rehabilitation has a very strong component of subjectivity, and we may see an objective improvement. We may see that somebody's range of motion has improved by 25 degrees, but it may not make a difference to the patient. The patient may say in their whatever subjective questionnaire that they are feeling better only by 1 point, and the MCID for that particular tool is much greater than 1. So your objective measurement may not have complete relevance to the patient. And therefore, many of our tools are different. Our tools are dependent on subjective and on outcome measures. Interpretation of statistics is very important because some of the things that we need to, some of the aspects that we need to consider when we're doing statistics is the effect of covariables. And we need to also know, because you're doing, let's say you're doing an exercise intervention. What is the peak duration? When is the maximum effect happening, and how long does it last? And when does it taper off to back to baseline? So these kind of things are important to us. Therefore, so that we know the dosage, how long we should employ the treatment, how long we should tell them to continue the program, how often we should see them again for booster doses of exercise or whatever. So the interpretation of statistics and the statistics itself become very important. Now, rehabilitation, like I said, because it is an interaction of social cultural factors also, many of the questions that are important to us would be country specific. It would be specific to India. So we cannot probably depend on other people's results completely. You can to a certain extent, because if you have a physiological variable, then you're not expecting it to change between countries. But there might be other aspects that are completely different. For example, if you're looking at the outcome measures in musculoskeletal therapy, for instance, many of the functional questionnaires do not address many of the functions that are essential for Indians. And so the validity of this questionnaire itself for our population is questionable. So you may make a great difference in that, but the things that are most important to your patient has not been addressed. And therefore, rehabilitation strategies that you have employed may be less than optimum if they have not been addressed. So these are, because questions are country specific or India specific, we in India need to make our own research, need to make our own well-planned, well-designed, well-executed, and well-interpreted and well-reported research. Now, there are many, like I already said, there are many covariables that are more than physical characteristics, attitudes, behavior, adherence, boredom, motivation. There are so many other things. So all these things are some of the things that we need that are different in rehabilitation research than the basic medical clinical research, and therefore the new arm of research called rehabilitation research, which really hasn't taken off in a big way in India. Statisticians in India often do not recognize it as a separate entity at all because they continue to tell us what to do using epidemiology, which is a major strength of Indian researchers as of now. The statisticians. So they are looking at that, and they're not really understanding or trying to teach us the things that are relevant for rehabilitation research. Any typical research course will talk about epidemiology to a large extent. There's a lot of emphasis on epidemiology, very little emphasis on measurement, and then there will be a lot of emphasis on clinical control trials, and very little on other types of research, and hardly any research course that is done in any medical college will deal with qualitative research. Qualitative research is considered to be only social science research and something that does not come into healthcare, whereas it is an essential part of rehabilitation research. The rehabilitation professionals ourselves have not recognized that our research is probably different, and therefore the levels of hierarchy, the levels of evidence, the hierarchy of evidence, and so many other things may be slightly different in our condition, and there might be other things that are important to us. We are also not yet completely aware of this difference. Medical community, when you talk about it, they rebuff it saying, oh, what's the difference, sort of thing. So that very often when people go to ethical clearance for ethical committee clearance, which is usually dominated by medical professionals, and when you talk about your research aims and your methods, etc., they rebuff it. And they often say, what is the need for it? There is no ethical consideration. There are ethical considerations even for rehabilitation research. There are a lot of ethical considerations, but they very often are not able to understand it. But funding agencies, this is very heartwarming. Funding agencies are beginning to recognize that our research is very important, especially with the burden of NCDs becoming larger. Rehabilitation research is a big thrust area in ICMR, and they are recognizing and they are able to identify the good studies, and this is very good news for us. But they are still heavily dependent on epidemiology and on RCTs, because the reviewers are often medical professionals, and more than that, the health priorities of India are still on epidemiology. We need to understand the burden of disease. So many of the things that we may write, some of the objectives may end up getting changed. Now, to me, physiotherapists deal with disability, and they deal with disability only at different levels. It may be temporary, it may be permanent, but whatever it is, whatever we are doing is all related with disability. So when you look at disability, as seen in the ICF model, it is multifactorial and often lifelong. Therefore, our research foci must also be at various levels. RCTs, randomized control trials, are very good if what you want are short-term effects, provided the outcomes that you are measuring are robust outcome measures which are interpreted accurately and which are meaningful to you as a professional and to the patient. Outcomes have been validated in our population. So if you have an outcome measure but it has not been validated in our population, then the results of your study are questionable. If short-term effects are more important than long-term effects, RCTs are the designs of choice. And if a cure, or in our thing, if decrease of symptoms to baseline, we can consider as a cure. If a cure is a possible outcome, then definitely go ahead with RCT. Coming to epidemiology for us. Now, the things that we need to look at would be functional status, physical profile. What is the disability understanding of this? What are the disabling factors? What is the process of disablement? Nobody has considered these as epidemiology, whereas I like to consider them as epidemiology because they are also characteristics of the disease or characteristics of a condition. And therefore, I would like to use the term functional epidemiology. This is, I think, only I'm using it, nobody else is. But anyway, we have very little information on how a person who is a stroke survivor, what is the natural history of the disablement in India. For example, what happens? We are heavily dependent on long-term research coming from other countries. We don't have a clue about what happens to our stroke survivors in 5 years. We are looking at it since still from a medical point of view, a medical viewpoint, and even now, if you ask what is the goal, they will say to normalize function. Now, we're not going to normalize function. What we are doing is minimize dysfunction. So we need functional epidemiology. Now, some of the questions. What are the important functions that a person with knee OA finds difficult to do? Do we know this? No, we don't. That is in India. Now, in India, there is differences. What happens in north may be different from what happens in the coastal areas, might be different from women, might be different from rural, etc., etc. So all of this is also a sort of epidemiology. What are the important functions that a person with shoulder adhesive capsulitis finds difficult? We don't have any outcome measure for shoulder adhesive capsulitis or OANA that is completely relevant to India, where the stakeholders have been involved in making the questionnaires and so on. What are the most important measurable functions that an older CVA survivor needs? We don't know. We are assuming that they need to use the hand. We are assuming that they need to walk, but we have not actually done. These are theories. These theories have to be proved by large-scale studies. And we are looking at a top-down approach or a medical model defining function, and we are what is our comparison group? Normal function. So we are saying any deviation from normal is a condition, and we need to try and bring it back to the closer to normal. We have not considered until recently that this eagerness to bring the function back to normal is probably decreasing their number of functional years that secondary deformities, the secondary disabilities may occur. Of course, nowadays we are aware of this. Then some of the other questions. Why do we believe that sitting on the floor is not an attainable goal? If a patient with who's a stroke survivor says he wants to sit on the floor and eat his food, our knee-jerk reaction is, I'm sorry, sir, that may not be possible. Why not? Have we thought about it? Have we looked at the task? Have we analyzed the task? Have we figured out a way to make this person sit back on the floor and have his food? No, we haven't. These are all epidemiological, in my opinion, studies that we need to undertake. Coming to observational studies, a large number of our research in rehabilitation in India at the moment needs to be observational studies, because rehabilitation research in India is in its infancy, actually in its neonate period, and therefore we have no information. And for information to be acquired, we need exploratory studies. Exploratory studies have to be observational, without any hypothesis, without the burden of having a preconceived notion. We need to just observe. We need to look at the natural history. We need to look at participatory function, functional management. We need to see how people with CVA have coped, and we have to learn from that. And then involve that, put that into our treatment strategies, and so that we can make it evidence-based. Now, observational studies pretty much are considered the poor cousin of medical research, because meta-analysis is the strongest brother, and so on. But in our case, this may not entirely be true. We need to observe our phenomena, and then we need to test it. So we need to have large-scale observational studies in rehabilitation research. So since context is an essential component of disablement, this has to be done within our country, taking into consideration all the contextual factors that theoretically are important. Now, once this is over, if you have baseline data, you have the exploratory results, the results of an exploratory study. Then what? Then we need to find out what happens in the long term. Now, how many people with disability go and live fulfilling lives for the rest of their lives? Maybe they don't even need a physiotherapist. Have we considered this? No, we consider that we always need to interfere, but maybe we don't. If we observe, we might know when we should interfere and when we need not interfere. Then disability is an evolving entity. We need to know what happens at future time points. This is especially true in childhood disability, where we spend so many months and years of the child and the parent's life trying to make the child walk, or often to me irrelevant aspects of function, like saying crawl, crawl, crawl. We're spending days and hours and trying to make them crawl. And we are saying they have gravitation insecurity when we're doing something. Whereas probably the only thing the child needs to do is keep on falling and the gravitation insecurity will go away. Perhaps. I don't know. And we need to know, if we spend so much of our time in trying to make this child normal, which means we are assuming that the child is abnormal, what happens to everything else that the child has not attained, and what will happen in the future? If we put them in an AFO at age 3 months, what happens to the architecture? What happens to the bone formation? What is happening to the muscles? What is happening to the length of the muscles? What is happening to the ligaments? What is happening to this child, which may affect the child when the child is 6 years of age, or 16 years of age, or 60 years of age? These are things we need to understand. So long-term follow-up is essential. These are all the pressing needs of rehabilitation research in India. And how do we do this? The only way to do it would be to have a registry where every child or every person with a particular condition is registered. We can do this even at a local level. Every person coming to individual hospitals, or those of us who have established or establishing community outreach centers, we can do a registry. It is not that difficult. We don't require that much money. Everybody has a system, everybody has a medical record system in their colleges. So you enter it, then pass it on, make this into a department goal that we will follow up stroke patients, all stroke patients who are there in the registry, we will follow up every year. And so whether you are there, you leave the college, somebody else comes, this becomes a departmental objective, and this is how we will make meaningful rehabilitation research. Another thing that we read, when we read in literature, we read the RCTs, that this new thing was compared with usual care. What is this usual care? I have not understood the identity of this as yet. What is usual care? To me, there is no such thing as usual care. My care is dependent on the patient. My care is dependent on my evaluation findings. Of course, I know what is meant by it is that it is just care that does not have healing. Meaning you're giving hot packs and you're giving quadriceps exercise or something like that. But what is usual care? If it is usual care, we are assuming that it is common, which means it has been carried on for years traditionally. In which case, is it a useful entity? Is it supported by empirical evidence? Should we be researching usual care? Yes, we should be researching usual care, because we need to understand, first of all, what is usual care. So if I send out a questionnaire and say, in your opinion, what is usual care for back pain? If I'm quite certain it's not going to be homogeneous. Each person is going to have their own opinion. So there isn't such a thing. So whatever this is needs to be spelled out. What we mean by usual care is what is carried out in our hospital, which is this. And then we need to research that first, because if it works well, we don't need any other new RCT, we don't need any new approach. Now, is this usual care codified, so that if I say, if a person with low back pain comes to my department, on the first day, we will take mass. Okay. If the mass is less than 6, then we are going to teach them basic flexibility exercises within their painful limits without pushing the limits of pain. We are going to give them a pain relieving modality if necessary, that is a hot pack or ice, and then we are going to follow them up every alternate day for 3 weeks. And then when the pain has reduced by at least 3 from the initial, then we are going to go on. We're going to do a full examination, and we're going to go with what is the uh, uh, based on the condition. So if it is if it requires repeated motions, we're going to do repeated motions and so on. So this would be usual care, very broadly. Now within this, you have to say, when this patient comes in, we're going to give blood packs for 20 minutes, followed by gentle stretching of hamstrings, or sitting in a chair, feet on the ground, leaning forward till the limits of pain 3 times. So if you say this, if you codify it, if you make it into a protocol, then you know that we know that it can be replicated, and we know that whether, and we will be able to assess whether it is doing any good. Now, often we write terms like pain relieving modalities. Does it mean that all pain relieving modalities work in the same fashion? This is what we have learned from our teachers, passed down from teachers, that should be passed down, not asked down, from teachers who are not very clear on the physiology behind it. Anyway, the physiology keeps on changing. So these kind of things are what is making rehab research a laughing stock of medical research. So we need to make all this better. Quantification of what we do. Now, if a doctor reads that that this person was given ABCD drug, automatically they know how many mgs and how many times, because there is a standard, there is a dosage, there is a prescription, there is a dosage prescription based on body weight, etc. So it is understandable, it is interpretable, everybody knows what it means. Whereas we don't have any idea what another physiotherapist is doing. Somebody says they have done aerobic exercise, we don't know, they did 20 minutes, 30 minutes, 40 minutes, 50 minutes, what they did, we don't know anything. Exercise is also dose dependent. We need to write down the specifics so that we know what is the optimum dosage. Specifications are required for experimental and quasi-experimental studies, including frequency and duration. The outcome measurement is another big area of rehabilitation research, and outcome measures are measures that are relevant to the patient. So it is not what is relevant, what is measured by the therapist, it is what is measured by the patient or the client. So measurement, therefore, must be sensitive to change with a specific intervention. So you must choose a measurement that is sensitive to change with a specific intervention. For example, one of the fashionable things to do currently in India, has been for some time, is to do quality of life SF36 or SF12 for every patient, even if the treatment duration is 1 week. You expect somebody's quality of life to change in 1 week? No. Quality of life is a learned behavior. For that learned behavior to be unlearned, it's going to take much more time. So it is not sensitive to change in 6 days or 5 days. But we do this casually without thinking about it. If we are expecting structural changes, we should be able to measure the structure. Extrapolation we can do, but only to a certain extent. If we are doing behavioral measures like participation and quality of life, there are many other contributing factors which we cannot control for. So we have to take this into consideration. So the effect must be very large for you to say that that whatever change happened was because of the intervention. Now, what is the outcome of interest, and how often and when do you expect it to occur, is something that again we don't seem to be very clear on. So we need to know what is our primary outcome of interest. Is it the structure? Is it function? What is it? And when do you expect it to change? So if you're looking at muscle mass, we know that it takes so many weeks before before the muscle is going to grow. So if you do outcome measure before that, you're not going to get any results. So these are some of the things that you must keep into consideration. So when you're doing outcome measures, first of all, before you do any study, the outcome measure must be chosen carefully. It must be modified or standardized. Reliability, etc., must be tested. All of this we will deal with in future classes. So the outcome measure must be robust, it must be sensitive enough to pick up whatever you're expecting it to pick up, and it must be employed at intervals which are meaningful. And who are the participants? Especially in thesis kind of research, we have a tendency to fit whoever is available. So you often hear, don't make the inclusion criteria too stringent, you will not get participants. To a certain extent, that is true because you don't want to make it too stringent because then it is not generalizable. But if you make it too heterogeneous, then you're again not going to get any sort of meaningful outcome. There are statistical ways of dealing with this that we will deal with later. Homogeneity in diagnosis does not mean homogeneity in disablement. So if you're saying everybody with OA, it does not necessarily mean that all of them are performing at the same level. So when you're doing inclusion exclusion criteria, either you should take that into consideration or you must add that as some sort of a covariate. Somehow it must be controlled form. So very often, rather than doing plain RCTs with a pragmatic design may be more honest, even though they may not stand up to the standard scrutiny as much as RCTs. The mixed methods design, or at least a clear description of individual patient characteristic, etc., will give a better understanding of what you have done, what you have achieved, and how meaningful it is to patients. Statisticians often discourage this, saying that it is confounding all the results, and you cannot help that research is median tendency and not individual. Now, this is true, but we also need to understand if there are different groups of people who behave differently, because that will allow us to make future hypotheses. So your design and your methodology must be based on what the aim of your research is. What is the aim of your research? If the aim of your research is replication in order to add to the body of evidence, then that's a different type of research. You are replicating, in which case you need to follow previous guidelines. If you're trying to do proof of concept, you have a new idea that you want to check. So then, in order to see if your beliefs or your theory is accurate, that would be an observation design. It would be the way it is designed would be different. If it is explorative, you don't have any sort of preconceived notion. You just want to know what is happening. You don't know what is happening. That would have a different approach to design, to research. And are you trying to bound the existing intervention? Are you trying to say this intervention is fine? It has been explored and it has been given in research, in articles enough number of times. I don't need to re-evaluate it, but I want to know how much or how long or when is this useful? That would be to give it some sort of dosage, frequency, etc. So that would have a different type approach to research. And if you're doing validation of measurement instruments, you want to know whether it measures the same thing in India. Now, these measurement instruments, I'm not talking about physical measurements, I'm talking about tools and scales, okay? Word measurements, where the word meaning or the concept or the understanding or the way the word is translated, etc., has a lot of implication on its validity. So for this, if that is what you're trying to do, the aim of the research will be, the approach to research will be different. And then finally, you have all this research, and then what do you do with it? And what we are doing with it is most of our articles don't see the light of day. Most of our research, our PG thesis, etc., done very well probably, are not being published because we are not. We don't have that focus. We don't have the discipline to try and get your paper published. And this is important because otherwise, every question, see, don't make a mistake that you are the only one thinking about one question. If you have thought of it, 10 other people at least are thinking about it right now, and another 100 would have already thought about it. Therefore, if it is published, we can progress. Right now, what are we doing? We are stuck, we are stagnating. We are doing the same thing. Every university is doing probably the same research over and over again without knowing that 10 other universities have done it, and if we combined all of that, we would have a wonderful meta-analysis to do. So the publishing is very important. The choice of the journal is important because we want to know. I mean, you have to choose a journal based on who you think the results of your paper are important to. The title is very important because it must be attractive. People should feel like reading it. And when should you publish it? You need to publish it as soon as it is done so that other people don't waste their time redoing it. Coming to barriers to research, this is very beautifully explained in one of the articles that was given to you, and it is no different for us. It is the same across the world. Now, for some of the other things, research is taught as a very dry and disconnected subject in Indian universities. I was taught biostatistics in my undergraduation in 1982, and it was very boring, and it was at 2 o'clock in the afternoon. And somehow that is still the situation. My students now have research at 2 o'clock in the afternoon. I don't know why. It's very dry. It's disconnected. And most physios don't have a very strong background in maths, and so all the equations just go over our head, and they stop paying attention. The most important aspect, rather than statistics, the importance of research very often gets missed in this. And more than that, another barrier is from childhood, from school, our spirit of inquiry and curiosity are suppressed. And you're taught just do what is taught in the textbook, that kind of thing. And so when you come to a professional college, you have to recultivate the spirit of inquiry and curiosity, which by then is either dead or dormant. And they're afraid. They're afraid that when you question a teacher, it might be taken wrong, etc. But this is necessary. Unless you have a questioning mind, we cannot do research. And we have a problem with lack of confidence in our own question. We have a question and we think maybe it's a stupid question. So we tend not to research that, but rather go with whatever is easily available, like replicate something that's already done because that gives you confidence. If somebody else has done it, probably it is sensible sort of thing. But more than anything, the reason we don't have a body of evidence or the reason we don't have enough matter to do observational studies or RCTs is because of the complete lack of meaningful documentation in clinical practice. How questions generate is by doing proper documentation. So if you document every patient every day meticulously, you cannot but have questions. You have to have questions. You have to say, I have done this 20 times. Out of 20, 18 people have gotten better, which means what I'm doing is probably something worth researching. That is how you get the research. Now, what do? We treat a patient and we forget about them. Forget about them in the sense we forget about them in a knowledge level. But if at the end of the day you are forced to sit down and recall every patient and document on them, uh, and that documentation is going to be audited by somebody who says this is not adequate, this is not adequate, then I'm telling you, you will understand, you will be able to remember, and you will systematically process what you have done through the day, and then you will start to see patterns emerging, be it positive or be it negative. So this is our greatest problem, the lack of documentation. If at all there is documentation, we write treatment given, physiotherapy given, quadriceps exercise given, what given, we don't know what is given. So these are some of the problems, and this is one major problem we have. And we have lack of a clear lesson plan in education with student-generated assessment. All of our internal assessments are based on rote learning. You ask a question, they answer the question based on what is in the textbook. Although this has been well established from about the 1980s, the physiotherapy assessment must consist of reflective statements, essays, and project-based learning. This is not done. So, reflective statements. If you tell someone, I do this in my with my students, and if I tell them to write 1,000-page essay on what they have done in the past in the past rotation, clinical rotation, most of them are unable to write anything. They will give me 50 words, 100 words, and that will mean I saw 25 patients, 30 patients, I saw 25 patients with shoulder, I saw 10 patients with neck, I saw a stroke like that. That is not what I'm asking. I'm not asking for profile, I'm asking their reflection. What did they learn? What did they do? From that, what did they learn? But that they're unable to do. Now, the good thing is, if you take third year students who have just started clinics, they are much more verbose. My third year students are writing essays in 2000 words. They're not afraid. They're not afraid that what they're saying is wrong. So they're happily writing. And I get a lot more material from those third years and fourth years reflective practice reflective statements than I do from the PGs. Because the PGs think that if they write this, man's going to laugh or man's going to shout at me or something like that. Whereas the PGs don't have that problem. So these are some of the ways that we can start to inculcate the questioning mind. And we have a dependence on reproduction of esoteric theories which are ill understood. So if you tell them, they say all these fancy, things about water learning principle and what is the principle of PNF and what is this, and nobody knows what it is. Neither the teacher who's teaching nor the student who's learning actually understand what any of that stuff is. But we continue to learn this by rote, and these are some of the things that are suppressing our spirit of curiosity and forming a barrier to our research. Now, research is also considered a scary word because of lack of application. We consider that research is something that is done by many people or people who are interested in academics, and it has no meaning in clinical practice, which is not true. Research informs clinical practice, and clinical practice informs research. They go hand in hand. One does not exist without the other. And you have a concept that research is hierarchical, that only people with a certain frame of mind can do it. And that's not true also. You have different types of research. Everything that you question is research. Then, of course, something that we can do very little about, that is the need for funding and guides who can mentor, people who can actually mentor and make you do research that is exciting or interesting. Lack of cooperation between institutions. Each of us are an island unto ourselves. We are not cooperating, and so our potentials are narrowed down. And we have generally in our profession in India, we have a lack of mutual respect. All of us dislike one another or deride one another. We don't necessarily. These are some of the other barriers. Then you have this general attitude among clinicians that researchers are not good with patient care and that they are out of touch with patient care. And so somehow people who treat patients without reading books are better clinical practitioners. This is not true. If you practice evidence, you're obviously a better clinician. So researchers can be good clinicians. In fact, must be good clinicians. Then we have a focus on our patients getting better without measurement. You say, we did this, my patient is better. We find better, and he says he feels better. That is not empirical evidence that he is better. We need to measure. Unless there is measurement, we cannot say that the patient is getting better. Patient feels better either because he wants to stop coming, so he says, "Oh, I feel better," or he wants you to feel good, so he says he feels better. There are so many other factors. So these are some of the things we do. So when the patient gets better, we discharge them from physiotherapy without doing any measurement. So these are some of the barriers that we have. So what do we need? We obviously need more evidence. We need better evidence. We need our evidence, that is evidence that is meaningful to India, that is created from India. We need objective evidence, that is something that can be measurable and that's something that is time bound. We need a belief in evidence. Currently, we believe that evidence is for the birds. We have to do whatever we have been doing, whether it works, whether there is evidence or not. All the proprietary therapies are an example. I have done this for 1.5 lakhs, so I will do it whether or not the patient gets better or not. Even when the evidence says otherwise, these are things. So we have to have belief in evidence. We have to have discipline and we have to have confidence. Discipline to document, discipline to actually do what we have to do for as long as we need to do. And we need to have confidence that what we're doing is worth doing. We need to move away from depreciating ourselves with vague terminology like limb physio, physiotherapy, chest physio, etc. There are no such things. If we are doing exercises, we are doing a particular type of exercise. So that has a name. It is not called limb physio. We need to focus on quality rather than quantity, rather than saying I treat 500 patients a week. I would be happier to hear you say that I'm treating only 5 patients a day because I cannot help more than that. That tells you that there is quality and we need to do reflective documentation. We need to inculcate research in everyday practice and teaching. So every day when you take class, there should be questions that the students have to research. They have to think about. They must reflect upon. Then they must read and find out if what they have thought is correct and if it has been done before. If not, they need to find out for themselves. These will lead to design studies. If we have this kind of culture, then we will be able to design proper studies instead of randomly coming up with the study design like we do in MPT thesis right now. We need to have regular discussions on research and practice in a non-hierarchical, non-threatening manner, where the principal and PG student can discuss a patient without fear of ridicule or without fear that you will be failed or whatever. Teachers must challenge students to perform rather than obey. If they make mistakes, it's all right. Making mistakes, honest mistakes, that it does not harm the patient, is all right because that is how they will learn. That is, if they learn to reflect on their mistakes. We need to form some special interest groups. We need to believe in our findings and our needs, and we need to work ethically and professionally. So this is an introduction to what is rehabilitation research, barriers to rehabilitation research, and what I believe we need to do. So over the next 2 weeks, what I would like you to do is think of a frequently recurring doubt, write it or them down, you may have more than one. Start documenting patient care judiciously, regularly, and in detail. You can use the SOAP format, it works very well to start with. Because if you write narrative documentation like you do for the exercise for examinations, it becomes too unwieldy and you lose the focus. Whereas if you write a SOAP format, it's just there. The S is there, the O is there, everything is there. If you do that, you will identify consistent issues, and then from there you will be able to design a study, and then you form a research question, do the literature review, make the research question tight, find the outcome measures, and so on over the course of this 7 months. Please complete the questionnaire and return it, those of you who haven't. And please write a 1,000-word reflection on your current patient care responsibilities and the need and opportunities for research without significant funding in your current situation. And return those before the 18th of February. The next webinar will be on the 20th. Thank you and have a good evening.